afternoon, everybody. My name is Mario Alberto Battaglia. I am Professor of Public Health and Epidemiology in the University of Siena, but here I am in my role as member of the Executive Committee of the PROMS project. I've been a volunteer in the field of MS in the MS Society for more than 40 years, and I'm President of Italian MS Foundation. Welcome to this session. The title of this session is Challenges, the Patient Perspective. Starting from the first presentation that we had of the PROMS at the ECTRIMS and the Lancet article that was published shortly after, challenge was a word that for us is important. The challenge is the role of the person with MS, not only the voice, but the role, the active role of the person with MS that can play in this participatory governance and the key issue of representativeness. I have the role to introduce our keynote speech. And I have the pleasure to present you the speaker, that is Samantha Cruz Rivera. She is a research fellow in the University of Birmingham at the Center for Patient-Reported Outcomes Research. She has experience in trials methodology, systematic reviews and mixed methods, and conducting patient and public involvement activities. Her primary research interests are maximizing research impact, equality and diversity and inclusivity, and outcomes research, including methods to optimize a patient-reported outcome assessment in clinical trials and routine practice. So I have the pleasure to introduce Samantha Cruz Rivera, and the title is Equity and Diversity and Inclusion in PRO Data Collection, MS as a Case Study. Please, Samantha.
So, I hope you can hear me. Yes. So good afternoon, I'm Dr. Samantha Cruz, and it's an honor to be here today. So as already mentioned, my presentation today will be on equity, diversity, and inclusion PRO data collection. I want to talk on multiple sclerosis as a case study. So just a brief funding statement before I start. So the talk today is based on the publication Patient-Reported Outcome Assessment Must Be Inclusive and Equitable that was published early this year in Nature Medicine, and I'd like to start by thanking all the co-authors who made this project possible. So what's the link between equity, diversity, and inclusion, EDI, and patient-reported outcomes? So, but the lack of EDI strategies limits information about drug response and measures of safety and efficacy. It also limits the understanding of the impact of the disease treatment on patient symptoms and quality of life. Also, by not having EDI strategies, there's a lack of representation of the population who is historically compounded by mistrust of research and medical institutions that persist in many groups, in minority groups. And also there's a failure to include research participants which represent the target population, leading to suboptimal delivery of care. However, by having EDI strategies in place, we promote equitable healthcare, reduce health data poverty. So what's the aim of presenting this is to propose actions to promote representation of underserved groups in collection of PRO data. So before I carry on, I would like to give a definition of what is meant by equity, diversity, and inclusion. So diversity refers to respecting and valuing all forms of differences in individuals. Diversity is acknowledging and allowing to allocate resources depending on the needs of an individual in order to them to reach the same outcome as the other population. It's important to distinguish between equality and equity. Equality refers to providing the same resources to all people, regardless of the needs. And also we have inclusion, so it's positively striving to meet the needs of different people and taking action in order to create environments where people feel supported and are able to reach the potential. What is meant by underserved groups? So the definition of underserved groups is context-specific and may relate to demographic, socioeconomic, and health status. Examples include but are not limited to age, race, ethnicity, and sexual orientation. However, the definition of underserved group will depend on the target population, the question being asked, and the intervention being tested. So there are different barriers to PRO data completion. One of them is the lack of valid and reliable PRO measures. The development of PRO measures are often developed with limited patient input and may not address concepts that matter to underserved groups. Also, people with disabilities such as visual impairment, arthritis, cognitive issues, and general poor health might find burdensome or challenging to complete PRO measures. In addition, we have seen that there's a move of PRO data collection to be online. However, people with low literacy and high literacy learning and low literacy face issues, they're frequently excluded from routine monitoring and well-being afforded by PRO data collection. In addition, people who have lack of digital skills or access to digital infrastructure face these barriers. And it's estimated that 37% of the whole population in the world is digitally excluded. Therefore, living outside marginalized groups such as older people, people from low incomes, and other groups. Other barriers are racial and ethnic disparities. Frequently, we face the limited use of translated and culturally validated measures, and frequently, the density data in clinical trials is underreported. A recent systematic review of ethnicity and PRO collection in cancer clinical trials found that 17% of the trials included only reported ethnicity data, and none of the studies included reported the use of translated measures even when they are available. Another problem that we face in terms of inclusion of ethnic minorities is the shift to remote completion that has broadened the disparity in data collection. As we can see from the following graph, this is taken from this paper, which is Digital Disparities, Lessons Learned from a Patient-Reported Outcome Program during the COVID-19 pandemic. So in this graph, what we can see is that before the COVID-19 pandemic, PRO data collection was done in clinic via tablets, and only 14% of PRO data collection was done electronically. As we can see from the top of the graph, there are not these racial disparities in collection of PRO data. However, once the pandemic hit, there was a shift from PRO data collection in clinic to be done online. So as we can see from the bottom of the graph, from the year 2020, we can see that people who self-reported as Black of African America, the rate of response is as half of white people, and people who self-identify as Hispanic or Latino almost completely dropped in the completion of PRO data. Further problems are the inclusion of low and middle income countries. So participants from So participants from LMICs are often underrepresented, and there's studies suggesting that there's a correlation between income and the collection of PRO data. For example, so this means that PRO research is most likely to be done in upper middle income countries such as Brazil, Russia, India, China, and South Africa, and this is most likely to be done in low-income countries. But why this is? What are the reasons behind it? It's because in low-middle-income countries, there's low literacy, there are language variation, and when there is PRO administration, collection of PRO data, this might be done by an interview administration, which might introduce bias. And also, when we have a protocol published on how to conduct a clinical trial, there might be variety in how the trial units adhere to these protocols. So in this paper, we propose 6 different actions to promote representation and participation of underserved groups in PROs. So the first one is diversity. So involve individuals from all relevant demographics, identification of concepts, development of the PROs, measures, and data collection. Important to consider also clinical characteristics. So consider all range and severity of diseases, symptoms, and functional impact in order to include all population, all individuals from populations. Also important to look into cultural needs and languages, have culturally validated questionnaires. Also be aware of the literacy and high literacy of the population. So be able to include people with all levels of reading and writing problem-solving abilities. Take into account strategies to include participants so they are not excluded for digital reasons. And also it's important to engage with stakeholders, regulatory engagement with regulatory stakeholders from the beginning in order to put in practice and develop plans that include good strategies on PRO collection and EDI. I would like to invite you to read more on this publication, which was published already in Nature Medicine, as mentioned. You can scan the QR code to access the full article. And related to this paper, there's also the PRO ethics guidelines that was published earlier this year in JAMA. So in this paper, we discuss different ethical considerations in PRO clinical research. So you can also scan this QR code to access the full publication. And now I'm going to move on how EDI is represented in multiple sclerosis. What are the EDI challenges? So as already mentioned, minority groups tend to be underrepresented, and this is also the case in multiple sclerosis clinical research. So a recent systematic review identified 60,000 articles, and only 1% of these focus on African American and Hispanics. So if we look at the table on your left, my right, we can see that the incidence of multiple sclerosis in the Black population is higher than in the white population. However, the people, white participants tend to dominate the research. And also Hispanic and Latin people or Asian, and also Asian populations aren't represented. But why is important to look into this? Also, we already know multiple sclerosis manifests in different ways in different populations. And for example, in Hispanic population, it tends to appear at a younger age, and also it tends to appear, the disability tends to be present more earlier. Also, in African American patients, it presents greater retinal damage. It's also leading to an early disability related to the spinal cord movement. There are different PROMS that show that the different PROMS, such as the High Expanded Disability Status Scale and Multiple Sclerosis Severity Scores, that shows how this disability progression is in African American patients, which has led to the so this research that has been conducted has not led to any better outcomes among this population. So how did we get there? What are the barriers to health research participation, specifically in multiple sclerosis? So there's lack of access to multiple sclerosis information. There's not enough information about the trials that are going on available for participants, for patients. Also, there's a lack of bilingual information material or research staff to help participants who have any questions. Also, participants are frequently concerned about the harms and adverse effects, which links also to the lack of bilingual information. How can we explain those participants who may have any questions? And also, it's a historical mistrust of the process. So many participants do not trust in clinical trials. So it's important to educate the participants and share with them the benefits of clinical trials. Also, African Americans and Hispanic people tend to be diagnosed at a late stage once the MS has progressed, which is a barrier. And also there are logistical barriers, which mean like there's a lack of transport for participants to get to clinical trials. So MS are conducted in centers that need high advanced technology, and normally these centers is to be in cities, so they are far away from where these people who are disadvantaged live. So there's a need to develop strategies to help them get to these centers. this is another study. So this is a systematic review that focuses on the reporting of minority ethnic groups in phase 3 FDA-approved DMTs in multiple sclerosis. And this systematic review identified 45 clinical trials. And as we can see, of those 28 clinical trials, 93% of the population are white. In 14 trials, only 1%, almost 2% are black, and 11 is less than 1%. So, so going further about this on the representation in clinical trials, this systematic review identified that only 38% of the clinical trials included did not represent ethnicity. 31 reported the race and ethnicity as proportion of white participants, and only 31% reported 2 or more races. So what are the consequences of not having strategies, EDI strategies? This limits the generalizability of MS trials results, which means that the results published might not benefit minority groups. There's also that the information available is insufficient regarding safety and effectiveness. There's also, as a consequence, this will affect the delivery of personalized care. Also will affect clinical decision making, because as not having the right information, we will not be able to help participants, and also will luckily help in perpetuating the mistrust among underserved communities. So, as we already know, we are aware that FDI has published in 2016 the first guidance on collection of race and ethnicity data clinical trials, and it has built on this guidance. In 2020, there was a further publication, and most recently, 2022, where the FDA guidance suggests to develop and submit a race and ethnicity diversity plan to the FDA. This is in order to broaden help include minority groups in the development of in clinical trials, in order to help the delivery of robust results and able to help the delivery of optimal results and benefit patient and society. So, in summary, it's important to develop strategies to promote representation and participation of underserved groups. This is essential to deliver equitable healthcare and reduce health data poverty. As we already know, there's a lack of diversity in MS clinical trials, which limits the generalizability of the results. But it's important to look at the difficulties faced by this population to integrate them in MS trials. So it's important to get to know these minority groups in order to help them be included in clinical trials and the development of drugs. And also it's very important to adhere to the FDA guidance and in order to enhance the diverse populations in clinical trials. Thank you.
We have some minutes for the discussion. Are there questions from the audience before? And then we have questions also from remote. Giancarlo?
Thank you very much. I think this is a very relevant point. From the other side, the prevalence of the disease is quite variable according to some ethnical profiles. So sometimes it's not very easy then to match both. Have you any data, for example, what happens when the MS trials are performed in Japan or in China or in Arab countries? So to see if you have the same problems everywhere. So it's not really determined by a predominance of the white Caucasian, but it's based on the composition of the population, because these factors interact each other.
Yes, of course. So when doing analysis of EDI, it's important to look at the population. As already mentioned, this is context specific. So if we're going to speak, we're going to talk about how MS affects in the United States. So on the subgroup will be people who self-identify as Black or Hispanic. Whereas if we talk about the UK, we will focus on people who self-identify as Indian or from Asia, from other backgrounds. So it's important to have into consideration these different elements. And as you say, see the proportion of of this population who's living in the UK or the US compared to the rest of the population. So we cannot just say this will translate it to every country. So for example, in countries who are less diverse culturally, they may not face these problems as bad as other countries do. Yeah.
If there are not other questions, there is a question from distance. Michael Thor. The question is, how do we ensure that from this point onward, that the PROMS initiative is inclusive, particularly including individuals from low middle income countries and individuals of underrepresented ethnicities, African, Latin America and Asian?
Yes.
What is your suggestion? Then we can ask to the...
I mean, I wish I could have an answer and a strategy so we could implement straight away, but I think this is a process. But as already mentioned, the 6 points earlier given today, we can start looking at how to include patients from the beginning. So patients should be included from the beginning of the design of the trial. So get to know the population, the target population. So trying to understand why not included, how can we include them from the beginning? And also collaborate with different stakeholders and the experiences. For example, for similar diseases, similar conditions that have gone through this process. Also very important to adhere to the FDA guidelines that they provide some important points on how to do this. And I think, as already mentioned before, patient input is essential. So I think those would be the initial points I will mention and take into consideration digital exclusion and have other modes to complete PRO questionnaires like normally tend to do, now we're shifting to electronic PRO data collection, but also have different plans, different strategies, for example, like telephone completion of PROs or paper-based to help make sure we do not exclude people.
Of course, the technical opportunities can offer a wider involvement of people. We can also consider, I don't know what is your opinion, all the research on real-world evidence, the contribution that the registers can offer to implement this evaluation. If you have a comment, otherwise there is another question.
I have a question.
Who? Okay, Gilles.
Yes, I understand it. It's true that in clinical trial, the recruitment of patients might be influenced by the social environment. But we have the observational study that help to correct these differences between population. And do you have any example in MS clinical, in MS, that with observational study, we change our mind on the usefulness, the efficacy, the level of efficacy of a drug according to some social characteristic or ethnic characteristic?
I'm not aware of any study that has changed because of that, because of the inclusion of a study of afforded subpopulation. However, it would be an interesting, I don't think there's something available, but I think there's something that we could look into to better understand how the drugs that are available maybe are not meeting the needs of these populations. But short answer, no, I'm not aware of any MS study.
Okay. There is, if you don't have comments on this issue, there is a question for you. Why do you need to know the sexual orientation of patients, if you consider this?
That's an interesting question. I think this will depend on the disease that's being studied. This might not be relevant to every disease that's being assessed, but it might be relevant to different clinical conditions, so it will help to inform better the decisions and might help to develop strategies to help the patient further.